clinicians, people in healthcare are data driven, and they're competitive. Nobody wants to be a leapfrog D. They want to be a leapfrog A. Nobody wants to be a CMS 1 or 2 star. We want to be a 5 star. And when you put that data out there, nurses and doctors and physical therapists and everybody that's involved, they get on board. And so, it's not easy, but it seems to be a pretty basic formula that what gets measured gets done. And when you put that information out there, people do what they have to do to improve the quality.
The business of healthcare is hard, creating a badlands of terrain that is difficult to navigate. Some think the most brilliant minds in business are on Wall Street. They are wrong. The most brilliant minds are in healthcare. They have to be to thrive and survive. This podcast explores concepts in leadership, management, sales, and negotiation with those brilliant minds. The Healthcare Badlands podcast is generally planned, but unscripted, unedited, and uncut, so you get the honest and unfiltered experience. Your host is Dr. Tom McDougall, a 30-year veteran of healthcare with 23 years of hospital CEO experience. His guests are carefully selected experts from across the industry. They offer insights, expertise, and some great real-life, often hilarious stories. Now, let's jump into the episode.
Welcome to the Healthcare Badlands podcast. Today I have a very special guest with us. It's Keith Parrott. He's the president of RMC Health System located in Anniston, Alabama. Fantastic leader. I've known Keith for a long time. I've watched his journey. I've watched his path. And most importantly, I admire him as a man. So I'm very excited to have him with us today and to go down a few paths of really interesting topics. So Keith, welcome to the podcast.
Thank you, Tom. Glad to be here. Appreciate you reaching out.
Absolutely. Let's jump right in. I know you and I have talked at length about a particular topic, and because I have such admiration for you as a person, I'm just really interested in you sharing with our listeners about what you refer to as finding joy in work and leadership, because I think this is a challenge. A lot of us call it burnout, but it's not really burnout. It's maintaining and finding our joy and happiness as we lead others. So talk to me about your beliefs on that and what you'd like to share.
Sure. Thanks, Tom. Probably the thing I enjoy the most about working in healthcare and having leadership roles in healthcare is the people aspect, developing relationships. Done this for a long time, and when I reflect on kind of the highs and lows and the things that bring me joy, the things that bring me joy relate primarily to people. Developing relationships with people that work for you, with the community, with physicians, with board members, and helping teams perform better, helping leaders grow, and it's just that relationship aspect. You mentioned my career has taken several paths, and part of that path was some time away from healthcare. And while it was a good time to recharge, the thing I missed most was people and just meeting people where they are and, learning about them and helping people achieve their goals. So that's probably the main thing. The second thing is just improving operations. And traditionally for hospital CEOs or healthcare CEOs, that centered a lot around the financial performance. I think the things that have brought me the most joy in terms of improving performance have really been more about quality. If you look at, when I first started, a successful hospital administrator was somebody who just kept the doctors happy, so they would admit their patients to your hospital. And over time, appropriately so, the expectations around hospitals and health systems to be held accountable for quality outcomes and patient safety. I've learned a tremendous amount and have really enjoyed seeing, big improvements in mortality rates and infection rates and just really delivering better care to people. Certainly a patient experience and all those things, but, helping people grow and helping improve the outcomes we deliver, those are things that probably bring me the greatest joy about the work we do.
Very interesting. And I know you've been with different types of organizations, and you've I can think of one particular situation where the organization went through a merger.
Right.
So talk to me about how you processed that experience and how you remained grounded and focused on what was
Sure.
most important.
Yeah, I mean, mergers and acquisitions are certainly a big part of healthcare today, and I've been through, two or three different versions of partnerships and joint ventures and things like that. Healthcare is very complicated, and there's a lot of gray. And I think part of our job as leaders is to simplify things and make sure you keep the main thing the main thing. And so, probably the thing that helped me the most is anytime I join an organization in a leadership role, I really spend time getting familiar with, bylaws, the mission statement. What are the people who started these organizations 50, 100 years ago? What drove them and what did they want, especially with not-for-profit health systems? What was the goal that community leadership group wanted in terms of establishing that entity? And, when you boil things down to why do we exist, what's the purpose, it really helps provide a lot of clarity around tough decisions and which way you need to go. When I led the Baptist Health System in Birmingham, we had come to a decision where we needed a partner. A path forward as an independent organization really wasn't a viable option for us. And as we evaluated different partners, on the surface, it might be clear, well, this partner fits or that partner fits. But that was surface. And so what you had to do was you had to get down to, what are the top 3 to 5 issues we need to solve for, and who's the best partner to meet that. And that helped us, helped our board, helped our leadership make some tough decisions that, on the surface may have been kind of confusing to people, but when you really got down to why do we exist, what are our biggest problems we have to solve for, and how do we continue to serve that mission, it made those tough decisions a little easier to follow through. So, it sounds kind of simple, but I think a lot of times it's hard for people to stay focused on, the big picture. And that's one of the things that's really helped me and helped organizations I've been with in terms of evaluating how to handle joint ventures and partnerships and things like that.
Interesting. Well, I think a lot of times in those situations, you're evaluating strategy. You're thinking
Right,
about strategic topics.
right.
But how did you, going through those experiences, how did you evaluate the cultural fit of
Yeah.
the suitors that you were hearing from?
You know, that is probably the thing that gets the least amount of attention and is the most important aspect, is that cultural fit. If I think about through the years, not just organizations I've been involved with, but looking at from the outside at other, partnerships that maybe didn't work, um, the strategy can make a lot of sense, but what's the saying? Culture eats strategy for breakfast every day. It's
Right.
you cannot underestimate the cultural fit. And I've seen organizations who, again, on the surface, you would think these cultures should really mesh and fit. But there were nuances in those cultures that made it very difficult to come together. Especially when you're trying to put together legacy, and in particular legacy faith-based organizations. Faith-based aspects, the symbolism around different religions, and the history. It's hard to ignore those and create something new, because a lot of the people that are involved with those organizations, they have a very strong attachment and affiliation to those legacy symbols and legacy cultures. And the worst thing you can do in those situations is kind of push those aside and not be transparent about the differences.
That makes total sense.
Yeah, and so when you're bringing together especially large organizations with multiple hospitals that serve different communities, sometimes you've got to have some flexibility and allow the culture of that broader organization to vary from community to community, because at the end of the day, you have to connect with the community. And if you're driving an overarching brand or culture that may not be well received or feel like it's pushing out an old culture, you can actually damage your ability to connect with that local community. And so I think it's important, especially as we see continued mergers and acquisitions, you know, as you're thinking about the culture of your organizations, you've got to make sure that the culture you're driving does not alienate people in that local community. You got to be focused on how do we connect with people in the community. It all starts with understanding who you serve and making sure you have transparency and trust with those people. That goes a long way towards success in those types of situations.
Yeah, that's an interesting thing, and I'm sitting here thinking about some of the organizations I've seen go through one of those
Uh-huh.
significant changes. Where, to
Yeah,
your point,
yeah,
it's got cultural implications, maybe as
yeah,
significant as the strategic.
yeah,
One of the things they do is they rename the organizations. They may come
yeah.
up with a brand, a complete new
Sure,
brand, but in
sure.
other situations, if they don't keep exactly the same name, it's a name that's
Mhm.
awfully close.
Right, right.
And what's your take on that? Is that
Yeah.
how does that impact the community?
That Tom, it's a great question, and I'm going to follow up on the last question as a segue into answering this question. So, lessons learned around culture. When I ran the Baptist system, we merged with Brookwood Medical Center in Birmingham, and so you had long-standing, successful Brookwood Medical Center. You had the Baptist Health System and our culture and values, and strategically, that made a ton of sense. And when you looked at from a value-based care, trying to really build an integrated health system that had not just the geographic coverage, but the specialty coverage you needed to deliver a narrow network product and deliver on value-based care, it was a slam dunk. It made a ton of sense. Um, the nature of those negotiations were such that we really weren't able to involve uh, a significant amount of physicians or medical staff in the negotiation. It was kind of like, okay, we think this makes sense, and then we rolled it out. And again, one of the things we ran into was while it made sense strategically, the medical staffs on the Baptist side and the Brookwood side really didn't understand it and didn't like it. Their cultures were very different. And a lot of the success that we needed early on were medical staffs coming together and collaborating and partnering and working together. Well, they had spent years competing and beating up on each other, and and that was one of the things that really hurt us early on was culturally our medical staffs were not on board, were not bought in, and that slowed us down. So that'd be another piece of advice. It's hard because a lot of times these negotiations, they're confidential. You have to be careful about that, but you got to really think through from a medical staff standpoint. Can these medical staffs work together? And so then you get into the naming. And I'll give you an example of an organization I think is doing a great job with this. Orlando Health recently came in and acquired Tenet's majority stake in what was the Brookwood Baptist Health System in Birmingham. Orlando Health has been acquisitive in Florida, internationally, and this was their first foray outside of Florida domestically. When Orlando Health moves in to look at a potential acquisition, they don't come in with an attitude of, well, we're Orlando Health, we're putting our name on all these buildings. They step back and say, okay, what name makes the most sense to connect with this community? So, for instance, in Tampa, my understanding is when they acquired a large Tampa system, they said, this is Tampa Bay. We don't need to put the Orlando Health name on these facilities. And so they didn't. Well, over time, my understanding is those facilities wanted to be a part of the Orlando Health brand because they felt like it added value. And that's the way that needs to happen. So you look at Orlando Health coming to Birmingham, they talked to physicians and the community, did surveys, and they determined that the best name for that organization was not Orlando Health, it was Baptist Health, and so that they went with that. I do think you see a lot of the systems that are trying to grow a regional and national footprint feel like it's really important to put that name on there. And I think, again, some cases that can make sense, others maybe not, but you have to start with the question of, naming is a big deal. And does the name mean something in that community? Do you have a legacy brand that has value that you need to build from? Is a legacy brand that has some baggage that you need to move away from? But you really have to be data driven and kind of set your ego aside and not worry so much about planting your flag on the building, but thinking about, okay, for this building to be successful, we need to connect, and that name is important. And so that's one of the things I've learned through the years being involved and just watching from the outside as you see branding and naming when you have mergers and acquisitions.
Very interesting. Okay, so here's a curious question that I want to hear your insights on.
Mm-hmm.
There are basically five parties that are affected when there's a significant merger or acquisition. And I'm going to simplify this, but
Yeah.
you have the C-suite that's impacted, you have middle manager, then you have frontline staff, and then you've got your internal stakeholders, which independent physicians, other organizations that have a relationship with your hospital. Then you have your external stakeholders. So from a cultural perspective, which party adapts the best to a significant change and which party struggles the most?
I think it's easy that the senior management struggles the most, especially when that senior management team has historically been independent and running its own organization. When we signed our deal with Tenet to merge Baptist and Brookwood, I told our senior management team, I said, look, for most of us, this is not going to be fun. We've gone from having complete, we work with the board, we set the culture, we make the decisions. We now are part of a larger entity, and we've got to get permission for things. And we've got to do things sometimes that are accretive for the larger organization that may not be what we would like to do here locally. And so it's always tougher on the senior management. Your titles are diminished, your roles are diminished. You've got to learn to work with people above you, whether they're good or bad leaders. It's just tough to give up autonomy, and so that group struggles the most. I think it probably flows down, then middle management. Most of the employees, they're not there for a particular brand, or they're working there because they have friends in the department, or it's where they've always worked, or they enjoy taking care of patients. They're focused on serving that patient in front of them, and as long as the new entity continues to treat them well, they tend to do fine and don't struggle with that as much. In terms of the external, that's so varied. It depends. One of the challenges is when a local healthcare system is acquired by a larger entity, that's can be tough on the local banks and law firms and real estate companies who are used to getting that business that now is going to go to whoever that larger entity has those relationships with. The community, hopefully you've done a good job and the community is getting better service and better care. So there's less negative impact there. So.
Okay. Interesting.
Yeah.
One of my early podcasts I recorded, it's a healthcare hospital CEO, in another state, but he talked a good bit about the loneliness of leadership. What's your thoughts on that? And, if you can share some experiences of what you felt over the years.
I don't know that that's a strong sentiment. I've never thought about that much on my own. I guess if you bring it up, there are some lonely moments. I'm I'm a very collaborative leader by nature. Um, some of that is, I think I have decent intelligence, but I'm not super smart. And so
I would
I need
disagree.
I need lots of help in terms of making decisions. And so I have very close relationships with my board chairs. It's very important to me that we have good relationship, that I understand what they and the board want, and that they know what's going on. Um, I've always viewed kind of my direct reports as more of a team. I really want them to feel comfortable to challenge me and push back. Um, and so I've always felt like it was more of a team sport. And so I, I've said numerous times, I don't care about Keith Parrott being right. I want the organization to be right. So my job is to put out a thesis and say, here's where I think we should go. Okay, shoot holes in it. And drive that process. So I guess when we're making tough decisions, I know at the end of the day, I've got to make the decision. I get all the credit or the blame, as does any leader. But I've always felt like it's been more of a collective effort to get there, and so it honestly hadn't felt that lonely to me.
Good.
But I have to give some thought about that on my drive home tonight.
I want to circle back to something you talked about earlier because I know you are very driven by quality improvement.
Hmm.
And I know you and you care as much about the quality performance of your organization as you do the
Yeah.
financial performance. But quality of the three big things, so finance quality and satisfaction or patient
Hmm.
experience, as it's
Yeah.
commonly referred to. Those are the three kind of pillars of performance for a hospital. But quality is the hardest one to turn around.
Yeah.
Um, what's your approach to that, and how have you been
Yeah.
so successful over the decades?
So I'll tell you, honestly, my experience has been that the patient experience is the most difficult to turn around.
Really?
That's been the tough. Yeah, I feel like um, quality has been an easier one for us to drive because it's a lot more metric focused. And so I'll give you a good example. Like I mentioned early in our careers, there really weren't there. It was, volume, financial performance, we're keeping employees and physicians happy. Then you brought in the patient experience. One of the first quality indicators was the core measures, right? Which
Right.
was, we had these measures and they were very process driven. And so doing well in your core measures was really about ensuring that you followed certain protocols and that your processes were good. But at the end of the day, it wasn't outcomes focused. And so one of the things we did early on in my tenure at Baptist was to say, okay, let's begin that transition from process oriented to outcomes oriented. Well, what's probably the most important and easiest to measure outcome? That's your mortality rate. Um, and clearly, when you look at mortality rates, you've got to adjust for severity and comorbidities. And so when we first look at our severity adjusted mortality rates at the Baptist Health System, they were like, I don't know, 1.2. And this is a ratio that you want to be as low as possible. If it's over 1, that means based on the data in the chart, you have patients dying who shouldn't be dying. If it's below 1, you have patients who are living that you kind of worked a miracle. The data would tell you you expect them to die based on their comorbidities. And I don't mind telling you because pretty much every organization I've been at, when they're not focused on that, the mortality rates are above 1. When they get focused on it, it gets down to 0.7, 0.8. And that was our experience at Baptist. And so when I first said, okay, or recommended, we need to have an improvements in our mortality rate as a goal for our incentive comp for senior management, there was a lot of pushback, and people said, well, wait a minute, there's so much, data and all this stuff that's not really, our mortality rates really aren't that bad. We just we aren't capturing all the data. And our response as senior leadership team was, well, then let's fix the data. And so over the course of 2 or 3 years, we lowered our mortality rates down to 0.75, 0.8. I would say 80% of that it's coding and documentation.
Right.
It's making sure that you're catching the infection that's present on admission so you don't get dinged with it. It's making sure that your physicians are coding and documenting appropriately what's going on. It's really about cleaning up your data. But there's another 20% that is, oh gosh, we got a process that's broken. We've got to improve this process so we make sure we eliminate any possibility that a bad outcome could come because of a bad process. You have, cultural issues where, timeouts in the OR to make sure you've got all the sponges or you're operating on the right limb. You create a culture where if someone breaks that, they get fired. We don't tolerate people being careless around those processes that we know are going. So you have to create a culture around, we don't compromise on that. And, there are physicians who probably need some oversight in terms of, patient selection types of procedures they're doing. So there is a 20% where you're improving actual care. And I've just seen this over and over again. Clinicians, people in healthcare are data driven and they're competitive. Nobody wants to be a leapfrog D. They want to be a leapfrog A. Nobody wants to be a CMS 1 or 2 star. We want to be a 5-star. And when you put that data out there, nurses and doctors and physical therapists and everybody that's involved, they get on board. And so, it's not easy, but it seems to be a pretty basic formula that what gets measured gets done. And when you put that information out there, people do what they have to do to improve the quality.
Yeah, excellent points. And Judd, based off of what you're saying, what I know about you, you're a very accountability-driven leader, and you pride yourself in that. But you're also a really nice guy. I mean, you're
Yeah.
like you got to be in the top 10% of the nicest competitors that I ever dealt with over the years, and I say
Thank
that
you,
as
Tom.
a big compliment.
Thank you.
How do you balance that though? So
Yeah.
accountability and kindness, a lot of people
Oh, yeah.
struggle with balancing those two leadership traits.
Yeah. So, by nature, I'm conflict avoidant, and I really struggle with that early in my career. I mean, to me, to sit down with somebody and tell them they were not performing, I was like, man, I don't want to hurt their feelings. I just, but, over the years, you realize if you really care for somebody, um, the best thing to do, the right thing to do is have the tough conversation. And if you don't care about somebody, the easy thing is to, not have those tough conversations. So, I've gotten to where I actually enjoy is probably not the right word, but I look forward to those conversations. And I think by nature, I like people and I want people to be successful. But also know as a leader of a hospital, I'm ultimately accountable to the patients who come in every day. And so you just can't, when you have someone who's struggling and not performing, you have to think about that patient who could be suffering because you're not having those tough decisions. And so I kind of start with letting people know that, I care for them and I want them to be successful. And so for the organization to be successful and them to be successful, we got to have these tough conversations. So my team right now, I've told them and I've told everybody, I like my team. I think they're great people. I want to be successful, but we're well paid and we have an obligation to deliver in return for that compensation, great outcomes for the organization. So we set very objective goals that we need to hit. And, I don't have a problem sitting down with somebody and saying, look, we're missing in these. What do you need? What can I do to help you get there? And so it really is a process of, look, I want you to be better because our patients deserve this. And when you come at it from that angle, it really helps. Also, because I'm as old as I am, I've been through enough to where I see the benefit of having those conversations. I see people either step up and perform better, or you kind of come to this realization that, this is a bad fit and you can't be happy doing this job because you're struggling. Let's help you find another way. Another thing I've learned is when you do have to separate somebody from the organization, they always end up okay. I mean, I've been on the other end of that, right? I've had someone say, you need to go find something else to do, and that hurts. But, you step back and you say, well, I'm going to learn from this and move on and be better because of it. So, but I think one of the things that helps with that is um, caring for the person. And because you care for the person, you have to tell them where they're struggling, what they need to do better to be better.
It's good advice. This episode is sponsored by CO Management Solutions, a revenue cycle company you may not have heard of, but you need to hear this. There is little healthcare organizations can do about inflation-related expenses, but you can make sure you're collecting 100% of your revenue you have earned. CO uses AI and the latest technology paired with an efficient team to aggressively collect your hard-earned revenue at an attractive commission. Start today with a free analysis of what you are leaving uncollected and recover that revenue quick with CO. For more information, visit coms.com. That is SCIOMS.com. Keith, let's switch gears to your various leadership experiences, different types of organizations, different communities. How has that shaped you as a leader?
Yeah. Man, that could be a whole 30-minute podcast right there.
Maybe that'll be the second time you come on as a guest.
Yeah, I worked for a large secular not-for-profit system in Houston, Memorial Hermann Healthcare System. Of course, faith-based not-for-profit in Birmingham. Then I worked for a publicly traded firm for a little while. I worked for a joint venture between a Catholic system and a Seventh-day Adventist system, and now I'm back in at RMC and Ascension. This is kind of a quasi-public entity with a lot more government involvement. And I've had so many different leaders that I've worked for and learned from them. I'll start with, and I won't go through all these, but just early on, Dan Wilford, who ran the Memorial Hermann system, where I did my residency and got the first, 15 years of my healthcare experience. Dan was an incredible leader, and you talk about relationship. I mean, this guy was off the charts with just relationships and connecting with people and staying focused on the mission. And, really so much of that success was his transparency, his honesty, his integrity, and his just ability to engage people and where they were going. And he was great with strategy and operations and all that too, but that was really good. The next leader I learned under was Dan Walterman, who succeeded Dan as the CEO of Memorial Hermann. Dan had good relationships as well, but Dan was off the charts on outcomes, having tough conversations, being honest about, while the organization was doing well financially and growing, we probably weren't where we needed to be from objective quality measures. And so really learned from Dan that, it's okay if you're a nice guy and people like you, have good relationships, but are we delivering the measurable results? And so a real ramping up of the focus on outcomes, not just financial, but everything. The other thing I've learned, there's a lot of debate about not-for-profit, for-profit, et cetera. To me, the tax status is less important than the culture and the people running the organization. Now, I will tell you, I think not-for-profits are in a little better place to really think long-term and take a long-term view of meeting community need. When you're in that publicly traded organization, those quarterly results drive so much. And there's times where you've got to make, short-term decisions to meet those short-term objectives. And it's a little tougher to take the longer perspective. But I would say that one is better or worse than the other. What really matters is the leadership at the top. Do they understand the mission? Are they living the mission, whatever that mission is, and how they're building their teams within the organization?
Yeah. I think there is a lot made out of the for-profit versus not-for-profit. Mm-hmm. Those lines have certainly gotten blurred over the years. It's much harder to be successful in any hospital than it was 20, 30 years ago. Not being, disrespectful of those that came before us, but it was easier times.
Absolutely.
And so, I heard somebody say, and it was years ago, it was a for-profit leader that was trying to convince my not-for-profit hospital that we should join them. And he said something interesting. He said, all hospitals are for-profit, or at least they should be.
Right.
And he didn't mean that he thought our hospital should become a for-profit. What
Yeah.
he meant is that all hospitals have to be in the business of making money
Mm-hmm.
because
Yeah.
you have no mission otherwise.
Right.
And, struggling financially, you're certainly not going to deliver great quality and
Right.
satisfaction outcomes.
Yeah.
And then I think we've further seen those lines blurred because there are a lot of talented leaders that are on the for-profit experience side that are now operating in not-for-profit
Mm-hmm.
organizations. So we've
Yeah.
seen this blurring of lines. So
Yeah.
it's been kind of interesting.
Well, and so back to culture. When I was working for Tenet, Ron Rittenmeyer was the CEO and chairman. Ron was very engaged. He made multiple visits to our market, met with frontline managers and directors. And you talk about integrity and transparency. Ron would tell our frontline clinical leaders, said, "Look, we're a publicly traded company, and we exist to give a return to our shareholders. Now, the way we do that is we deliver great health care. But we have an obligation to the people who own our stock, who've made investments, that we have to run this place in a place that gives them a return." And so I appreciated that. I mean, now I think some of the clinical leaders struggle with that because they heard profits first, but he wasn't saying profit is the most important thing. He was saying it's really important, but the way we do it is to have a great product. And so I think, probably the biggest difference is, if you're a publicly traded company, you've got to be generating EBITDA margins, at least 12, 15%. Not for profit, while that'd be nice, you can generate the capital you need to reinvest in your facilities at a lower hurdle rate there for margins. So that's probably the one thing where, if you're thinking about kind of longer term, making that investment in a community, there's a little bit more leeway for the not-for-profits. They still, they can't get by with losing money, but maybe the return on invested capital doesn't have to be quite as great because you don't have those shareholder returns that you have to worry about.
Yeah, makes a lot of sense. I viewed it a lot, and I spent a lot of time on the for-profit side. I viewed my role as the hospital CEO that was the top leader of the organization in the community. Is
Yeah,
my role was to kind of be the bridge. So
yeah,
yes, the corporate
hmm,
office shareholders, they're looking
yeah,
for a return, and to your point, exceptionally valid, that quality and satisfaction have to be there or you won't get the financial
right,
return.
right,
But
right.
I viewed my role as kind of being the bridge
Hmm.
between the care that's being provided to that community and the
Yeah,
objective to generate the return on investment that was
right,
necessary that the corporate office was focused on.
right, right.
And I, it's got to be the balance. It has to be,
Hmm.
or
Hmm.
there's not any success long term.
Right, right.
All right, so talk about how you invest in others. I know you spend a lot of time and energy, like I've done previously, in making sure this next generation of healthcare leaders has the skills and the passion and the talent to meet the
Hmm.
challenges that are ahead. How do you invest in others, and what values do you find most important that you're trying to transfer on?
Yeah. Um, a lot of it starts with the people that work directly for me. Um, and the best way a leader can have an impact on a large organization is how they treat and deal with the people that report to them, and modeling for them what that needs to look like, and making sure that that cascades throughout the organization. So when I sit down with my direct reports to talk about annual goals, the first place I start is, what are your goals? We're going to expect a lot for you. We've made it very clear what we need to achieve as an organization, but where do you want to go? And so if that's a COO who wants to be a CEO, if it's a chief nursing officer who wants to, do more, it may be that they're fine with their current role. They just want to be better at it and, be able to save money for retirement. But I think it's very important, before you ask employees, before you tell them what they need to do for you, understanding what they want to accomplish. And that needs to go to the frontline employees. if we're just saying, here's what you have to do so we can be successful, but we're not having that two-way conversation of what do you need to be successful. So I think that helps a lot. So really understanding where that person wants to go, and then mapping out a path to how to get there. So if they struggle with medical staff relations, okay, this is a weak area for you. Let's map out a plan to work on that. If public speaking or presentations is a challenge, how do we work on that? If it's a chief nursing officer, chief medical officer who wants to be a CEO, okay, how do we build up your financial skills? I think that helps a lot in terms of helping people grow. In terms of kind of leadership values that I really try to make sure everybody understand is transparency and authenticity. Most people can see through, the corporate speak. What they really want is they want to know what's going on, and just being yourself. One of the things I had to learn early on, I think about my mentors. I would see somebody who was successful, and I would try to act just like them, but then I realized I'm different from them, and so I need to take and learn from them what they're good at, but I've got to figure out how to make that authentic to Keith Parrott and not try to be somebody else. And I saw other junior executives who really, you could tell they weren't being themselves. They were trying to act like the people in charge so they could be in charge someday, right? And the people below you don't appreciate that. So they want to connect with you and kind of know you at a personal level. So that, the transparency and the authenticity piece are the thing I think we need most from healthcare leaders today.
That's excellent. Well, Keith, this has been fantastic. I've really
I've
enjoyed this.
Yeah.
Yeah. Well, your insights are very unique, yet they're not unique. And I guess your candor, the way you present yourself, again, I so admire the way you carry yourself. And, you're the leader of a very large organization. You're the face of that organization, but you're also Keith Parrott. You're a man, you're a person, and that shines through. So I admire you for that.
Well, and Tom, I want to thank you. I've enjoyed watching your career and the things you're doing now, just to help people learn and grow. And I appreciate what you're doing for our profession as well. So thank you.
And thanks for your time.
All right. Thanks, Tom. Have a good one.
Thank you for listening to the Healthcare Badlands podcast. As always, please like and subscribe so you don't miss future episodes. If you have suggestions for topics or guests, please email those to podcast@badlands.pro. This podcast is for informational and entertainment purposes only and should not be considered legal advice. Some information shared may include fictitious names. The opinions expressed are solely those of the host and/or guests and are their own and not reflective of the opinions of others or our sponsors. Thanks again for listening, and we hope you'll join us on the next episode of the Healthcare Badlands podcast. Until then,